thanks, James. Thanks for having me. Thanks everybody for arranging this, and everybody for jumping on at the end of a work day. So I appreciate that. Um, yeah, we're just gonna give you a brief talk here on the MTP, MIS MTP fusion system. It's just been launched just a couple months ago, so still relatively new, but it's already getting a lot of interest. It was at the AOFAS meeting just 2 weeks ago in Vancouver, and I was getting some interest there. So, I guess first question is, why an MIS MTP? As Chris said, and great talk, showing his experience with the clamp. Obviously, MIS is here. It's been really embraced quite a bit in the forefoot surgery, and I think we're starting to see, even in my own practice, being out for more than a couple weeks, that we're even adapting into new techniques, particularly in forefoot, is where I find it a lot more useful than some of the hindfoot options. But certainly bunionectomies, the hammer toes, Aikens, first metatarsal osteotomies are really becoming almost commonplace now as MIS versus open. And I think, like anything, as you get more experience, you get your hands involved with MIS, it starts expanding indications and opportunities where you might use it more. And so I think, we've already started seeing people do MIS MTP fusions, and, with the burr and the different burrs, doing that through small incisions, for the same reasons you would do any other MIS, better incision, better healing, potentially quicker healing time. Certainly patients love the idea of MIS, and frequently it has, less pain and swelling because it is less invasive. I think the downside so far with MIS, as far as MTP fusions, is, really kind of has relegated us just to doing 2 cross screws. And not to say that that doesn't work, but, that really, MTP fusions really changed significantly in the early to mid 2000s, where really these anatomic MTP fusion plates came out, and we saw significant improvement in fusion rates, particularly and the ability to let them weight bear early. So, with cross screws, we were typically having to non-weight bear the patient for 4 to 6 weeks. Or if you did weight bear the patient with cross screws, there was 10 to 15% non-union rate, sometimes dorsiflexion malunions because of the weight bearing. And that really changed dramatically. When we started putting dorsal plates with lag screws on, the fusion rates went up to 95%, and with immediate weight bearing if you wanted to. So that was been one of my kind of conflicts, is, if I was going to do MIS fusions or the MTP, I didn't want to sacrifice hardware and technique for an MIS approach. It didn't kind of make sense to me that, you're giving up on one thing to get another. These are just a couple studies that we published back in the day. Again, kind of just eliciting that fusion rates were 95–96% with a lock plate and a crossing screw. And that construct was really kind of the best as far as fusion rates and able to weight bear them earlier. The other advantage of using a plate for the MTP, whether it's MIS or open, is it kind of helps set the position of the toe. That plate's going to lay right on that first MTP joint, and if it's wildly off, you kind of know that you set the toe in the wrong position. It certainly helps resist that dorsiflexion malunion potential if you're weight bearing them early, like most of us do. So that's going to resist that, and it clearly gives us higher fusion rates. So the other interesting thing is, even in that 95% fusion, that means 5% possible non-unions. It's rarely symptomatic if you have a plate. So this was a really extensive study that Tom Rukas did years ago as well, looking at over 2,500 fusions. And so even in the 5% non-union, only less than 2% were symptomatic. So again, because the construct is stable, even if you get a non-union, it's rarely symptomatic. And I think we've all probably seen that in our own practices when you plate an MTP fusion. So again, kind of knowing all this information kind of brought us to, well, yeah, plate's great, but on the MIS side, it's not very practical with the current plates. And, some of the downsides of the plating has been hardware irritation. So even with the, anatomic plates that are more contoured and shaped, 10 to 15%, we usually have to go back and remove because they can feel the leading or proximal edge of the plate, or they're getting some irritation from the EHL tendon because the IP joint's still moving the tendon can get, scarred down or irritated from it. So, I've gotten used to that, and I would just tell patients, hey, we're going to put this plate on there, and there's a 10 to 15% chance we might have to come back in a year to take it out. But that's not really a great option if we can change that. So that's really kind of the impetus of where this MIS MTP fusion plate design and concept came from. We wanted to be able to have the benefits of the MIS plating or MIS joint prep. We wanted to have the benefit of cross screws, and if you still want to do cross screws, just one lag screw or cross screws instead of a plate, having a targeting jig that could help us do that. And then having the benefit of a plate, maybe a plate that could go through an MIS or MIPO type approach that would still allow the fixation and then be more anatomically friendly to the MIS approach here. And so that's what we'll see here. So kind of go through it. There's really this what I call kind of an S-shaped plate, and so this plate, there's a left and a right, and you can reverse it depending on where you want your lag screw. But the whole idea of the plate is it's got this kind of leading beveled edge, so you can slide it under the tissue once you've done a little soft tissue release. The idea is it's going to kind of wrap a little bit more to the sides of the phalanx and the metatarsal, so that you're really on either side of the HL tendon when you're putting screws in. So the tendon is really not where the screw heads are. And again, that's going to let less irritation there. And I guess it gives you the variability that if you want that dorsal to proximal lag screw, which has been my preferred technique, or if you want to do proximal to distal lag screw, you can go either way. The system is modular enough that you can do that and just kind of reverse the plate or basically use the opposite foot plate. And I'll show that in a second. So similar to other MIS techniques, you have to be familiar with using X-ray a lot and kind of knowing your anatomic landmarks. So you first just kind of identify where the MTP joint is, and you can mark that out with a marker there. If there is significant osteophytes dorsally, you need to take those down, because obviously for a plate to slide over there can't be a prominence there. So you can do that with the burr. And usually they do that at the beginning of the case, resect that spur down. The system actually comes with two different burrs. It comes with a 2.0 Shannon burr, 2mm Shannon burr. So that's the first one you start into the joint with. That kind of starts your kind of working portal from the medial side. And then once you've had that kind of started, then you can switch to this wedge burr. And that's what it's kind of doing the majority of the resection for you, both on the first metatarsal head and on the phalanx. And it's kind of handy because, the toe is still mobile, so you can manipulate the MTP joint around to help you, even burr correction out of there. If there's a valgus, you may resect a little more on the medial side as you're contouring the joint for the reduction of the deformity. And then if you've already done a colectomy, or you could make a little accessory portal laterally if you want, so you could evacuate debris or make a little incision to use a rod drill to get the debris out of there. The times that I've used this, once I've prepped the joint and I see this kind of good reduction, I usually will put the 2.0 burr back in there and almost use it like a drill bit and kind of fenestrate either side of the joint. That's just to make sure that I've got good, healthy surfaces there. And I'll usually try to pack a little bit of autograft in there if you want to. I tend to do that still. So just through that small incision that we're going to use to tunnel the plate in, we can pack some autograft into the joint as well. So this is a kind of a busy slide. I just kind of wanted to show you how you can use the plates and reverse them so that you can have the lag screw from distal to proximal or proximal to distal. Basically, the same side foot design as you see on the left foot, left plate is set up for the lag screw to go from proximal to distal. If you wanted to do a left foot with a distal to proximal screw, you just use a right foot plate. So it's very similar, very easy to flip that around, and the jig will let you do the crossing screw in either direction, or two crossing screws if you want. So just a couple pictures. Again, this is once you've done the joint resection with the burr, you can temporarily pin the toe in the corrected position that you want. That's what that pin is on the hallux there. And then we make a small incision. Pretty much if you did the chilectomy, it'll be an extension of that chilectomy portal for the burr. A little bit bigger incision there, so you can tunnel the plate under the HL and over the proximal phalanx. Once it's in the tissue there, we'll temporarily pin it, like you see on the picture to the right. And then the two distal screws go through the guide through small poke hole incisions. So we lock the plate distally on the phalanx first. You can then target the lag screw with the guide. This is again showing the proximal distal orientation. It comes with this 4.0 beveled head, partial or fully threaded screw. For this, once you drill the screw over the wire, before you insert the screw, you want to remove the pin, the temporary pin, so that you do get compression. You're pulling the toe back to the metatarsal. This little video will just kind of show you that as well. So again, that's about as big of the incision as you're going to need to tunnel the plate in there, and that's what you use to do the chylectomy for. You'll have a separate small medial incision to do all the joint prep. And again, you're keeping the toe mobile, so you can dorsiflex and plantar flex the toe to kind of work the burr around as you need. And then the plate should be able to go right in that first incision. You'll temporarily pin it. And we're not showing the toe pinned, but you could have the toe position pinned here if you wanted to already. And then get the distal screws in. That there's various sizes, locking screws, non-locking, that you can use there. And then this is a disposable guide that you can use. Has different trajectories for the lag screw. If you want it to be higher or lower, you have that variability. And then once the lag screw's in, then you can do the two proximal locking or non-locking screws. So pretty low profile construct. Again, all through pretty small incisions. The set is complete. It's got a little distractor in it. It's got also, in addition to the little MIS S type plate, there's kind of more of a standard plate. There's reamers. So if you wanted to do it open for whatever reason, you could always do that open with the same system. So it gives you a lot of versatility there. This is just one of the early cases from Jesse Doty, one of the other design surgeons, kind of showing you the traditional proximal distal lag screw. You can see the incisions there are quite small, so very cosmetically pleasing. I think what we've seen with using this plate early on is it really contours nicely to the toe, to the metatarsal and phalanx, so it's very, very low profile. And because again, it's kind of more to the side, it's kind of wrapping around that contour instead of being dead center. This is just one of my cases. So you identify the joint with a freer first, 2.0 burr second, get the 3.0 burr in there, wedge, get the joint prepped. I temporarily pinned the joint just so I kept my position in place. Got the guide and the jig on there for the slide the plate under. Then the two distal screws first, 4.0 screw, lag, and then the proximal screws after that. So again, you can kind of see how it kind of targets right between the screws. You're not going to run into anything. Here's another case I did actually just last week, open. So I decided to do this one open because she had really arthritic pain of the sesamoids. I needed to do a sesamoidectomy, and I needed to get that hardware out of there. So we did this one open with the same plate technique though. But you could just, again, kind of get a good sense of how the plate would fit, and gives you plenty of room for the lag screw in a low profile manner. So kind of unique. At this time, it's the only MIS MTP fusion plate system out there. It's the only MIS plate designed for this indication. So I think that makes it pretty unique. It's a nice system in the fact that you've got the standard options, standard plate, reamers, everything you can go to open if you want, and then the 4.0 screw. So you kind of get the best of both worlds. You got the MIS technique, and you got the superiority of a dorsal plate with lag screw. So this is the other design team members, Jesse, who's down in Chattanooga, and then Holly Johnson's up in New York City. The three of us kind of put this together. So thanks for your attention, and yeah, happy to answer questions this time. Thanks.
Okay, we've got another question here for you, Dr. Hyer. What is your typical post-op protocol for MIS MTPs?
So that for me, it's the same as it would be for full open one. You could weight bear them the same day. I don't. I make all my MTP fusions wait 5 days. So I put a big bulky dressing on them for the first 5 days. That's mostly to prevent a lot of swelling and pain and phone calls. And then so that 5 days they come for their first post-op visit. They go into a short boot. They walk on it. They walk full weight bearing on a boot. Usually for about 5 to 6 weeks. We'll be tracking them with x-rays along the way. So I'd usually tell them to prepare for a tennis shoe, athletic shoe in about 6 weeks.
Okay, great. And then got another question here for you, Dr. Hyer. Any tips for taking down the joint? And just to add to that, this has definitely been the biggest question that we've got, and we've learned a lot in this. And I think a lot of folks, when I was in that first case with you, they're always surprised after they do their first case
Yeah.
how easy it is to do.
Yeah.
So any tips on going through that, or what your experience
Yeah,
has been?
I think that's a really good question. It was definitely something I was suspect about. We've done plenty of them, in the design labs and stuff on cadaver, but I was always like, well, this is a cadaver. I mean, I could stick a freer in there and probably to provide it. Um, but so the first one that we did, live with the burrs and stuff, I did all the prep as we had talked about with the technique with the 2-0 burr first, the 3-0 burr second, contouring it, moving the joint. I tried to keep kind of a cup and cone shape to it more so than a flat cut. And then I opened it. It's like I had to convince myself, all right, I'm going to make a little dorsal incision there, and I want to look at the joint. And you're seeing the same kind of paste if you've ever done any MIS stuff. You're seeing the same kind of bone paste and stuff coming out of the other incision while we were doing it. And I flushed it a lot with the syringe and a little suction, Fraser tip suction to get stuff out of there. But when I opened it up, I was really shocked on how not how good of a job I had done, but how effective it was with the burr. So I'd say the key there is just making sure that you're spending time on both sides of the joint. By having the joint mobile, you can kind of bring the toe back to the burr or vice versa. So I felt like that was particularly on the phalanx side, it's a little more dense. So I was kind of bringing the toe onto the burr and kind of working it back and forth, but you could really get to it all through that medial incision. And it was a really significantly good debridement of the joint. I was actually pretty shocked on how quickly it went. I think that was another question here. I think I don't remember. I think it was like 26 minutes or so, 28 minutes or something for that first case. And I really wasn't trying to rush. It was just like, hey, I felt like I already did the whole joint. So it was pretty impressive that it was that effective. So if you haven't done any MS joint takedowns, I would suggest do it in a cadaver lab, 1 or 2 times, and then open it up and look at it. You'll kind of see, okay, where are the nooks and crannies that maybe I got to spend a little more time to. But since it's a pretty easy medial approach, you can get to it pretty effectively.
I think what I've seen you do as well with the small dorsal incision, just to take a peek in, right? I
Yeah.
think that's a great tip just to get comfortable with it and
Yeah, I
moving
mean,
it.
you're going to need that little dorsal incision anyway to slide the plate in. So,
Yeah.
if you need to, open it up a little bit more and just take a look, it's still significantly smaller than your regular open incision. So get some comfort with your technique first, and then you can get smaller and smaller over time.
Absolutely. All right, we've got one more question here. Do you use any particular device to get the autograft in the joint, or just pack through the chylectomy incision?
Yeah, so I just put it through the chylectomy incision. I'll use one of these instrumented reamer type deals. There's a couple companies that have one of those that you can do, small 6 mm dowel kind of thing that you can ream out of the calcaneus. So it's morselized cancellous bone. So you can leave it in the sleeve of that reamer and then just kind of use that as almost your cannula and pack it in through that incision, or just pack it in loosely. Because the incision will be about a centimeter or something to get the plate in. It's pretty easy just to push it in there with a freer and put it into the joint. But I use calc autograft. I don't use allograft for that.